And I would like to invite Dr. Kashef. He will talk about new insights on the classification of aortoiliac occlusive disease.
So, thank you, Mr. Chairman. I want to thank the organizing committee for inviting me to speak about the new insights in classification of aortoiliac occlusive disease. So, the new insight in classification of aortoiliac disease, this talk is about two parts. Part one, the general classification, and part two, the classification of juxtarenal aortoiliac occlusive disease. About part one, this classification is published in April 2023, aortoiliac occlusive disease, a novel classification system based on anatomical segment and disease severity for management planning. According to the author, the need of this classification is that the present classification of aortoiliac occlusive disease was essentially through the task 2 classification, which classified aortoiliac occlusive disease on the extent of the disease, particularly on whether the disease is simple or complex. As you see, this is the task 2 classification, task A, going through task D, and classifying the cases into task A and B, which is suitable for endovascular repair, or task C and D, which is suitable for open surgical repair, and would consider a dated classification. The rationale beyond the new classification is that the treatment of aortoiliac disease has changed significantly over the last 20 years with rapid development of endovascular technique, and the majority of aortoiliac occlusive disease in some centers are done through endovascular repair and not open repair. And the aim of this new classification is to plan surgery regardless it is open or endovascular. This classification is intended to be practical in nature and dividing the disease into a bite-sized pieces. The proposed new classification is based on dividing the aortoiliac segment down to femoral artery into separate anatomic zones, and the degree of stenosis is not important. Whether the arterial segment is stenosed or occluded is important to classify, as it may affect which technique is utilized and not the severity of stenosis. The location is also important. So what are these zones in this classification? We have A for aorta, C for common iliac artery, E for external iliac, and F for common femoral artery 5 millimeter. And we have S for stenosis more than 50%, O for occlusion, and 0, no significant disease, right and left. So these are the anatomical zones in the aorta. A0, no aortic disease. A1, aortic segment 5 millimeter, caudal to the inferior mesenteric artery. This is the inferior mesenteric artery here. Down to the proximal 5 centimeter of common iliac artery. A2, aortic segment 5 millimeter, caudal to the inferior mesenteric artery. Then to 5 millimeter caudal to the renal artery, and S3 aortic segment 5 millimeter caudal to the renal artery to the origin of lower renal artery. And this is collectively the aortic segment in this classification. And we have here A0, no disease. And then we have A1, this is A2, and this is A3. For the common iliac artery, we have CO with no significant disease, then C1, arterial segment 5 millimeter distal to the common iliac ostium, down to the iliac bifurcation, and C2 as C1 with involvement of internal iliac ostium, and then we have external iliac involvement, E1, arterial segment from the external iliac ostium down to the inferior epigastric artery. So this is connected with the aortic segment and the common iliac segment and then the external iliac segment. The major difference in the author's view in this system compared to the previous task 2 classification is that it is designed to assist planning treatment. So, as an example of A1, we have here involvement of aortic iliac of the bifurcation area, and we have here also an example of this. We also have an example, and the management, endovascular management, is through kissing stents. And this is an example of A2 segment disease. And this is an example of A3 segment disease. And the management here may be through CRAB or chimney CRAB of the lower iliac renal artery is involved. So this is an example of common iliac artery involvement, and this is an example of external iliac artery involvement. And this is an example of C1, 2, and E1 involvement and the management of endovascular. In conclusion, according to the author, management strategies for peripheral artery disease in general and aortoiliac disease in particular have evolved rapidly in recent years. Existing classification systems through task to steer the clinician toward a specific treatment. However, the first step in management and decision-making process is accurate identification of arterial segment which require treatment. None of the existing classification systems specifically address anatomy as an entity in itself. This new classification system provides intuitive framework based on letters and numbers that provide specific information for the arterial segment. It is developed to bolster this aspect of vascular surgery armamentarium to be used in decision-making and management. As regards the second part of this classification, this is a new classification for juxtarenal occlusive disease. It is published in December 2022, new classification for juxtarenal aortic occlusion based on imaging for safe clamping and contemporary surgical management result. To simplify this classification, this is type 1 juxtarenal thrombus reaching the base of one renal artery, and there is a space for intrarenal clamping or clamping down the last renal artery, as illustrated in this sketch. Then, type 1 juxtarenal thrombus reaching the base of one renal artery, and there is a space for intrarenal clamping. And this is an example of this type 1. Here, another example of type 1. Type 2 juxtarenal thrombus reaching to the base of both renal arteries, or one of the renal arteries occluded by the region, and there is a space for suprarenal clamping. And this is an example of this type 2. Type 3, no safe suprarenal clamp space due to eccentric thrombus progression, cranially on posterior arterial wall of aorta, or superior mesenteric occlusion by the thrombus. And this is an example of this type 3. Connectively, you have type 1, which allow intrarenal clamping, type 2, which allow suprarenal clamping, and type 3, which require supraceliac clamping. Options available: aortobifemoral bypass or thoracic aorta to iliac bypass, or axillary bifemoral bypass. And thank you.